Okay, good morning, everyone. My name is Bethel Mieso. I'm a general pediatrician and clinical informatics fellow here at Stanford. My work focuses on integrating AI tools into clinical workflows, specifically working on ambient AI. And I have the privilege of actually helping lead our enterprise-wide rollout of DAX Copilot, which is the AI scribe product here at Stanford Children's, as Tanya alluded to in her welcome remarks. Today, I'm honored to be moderating this wonderful panel, Next Generation AI for Pediatric Patients, with our distinguished panelists, and I'll take a moment to introduce them briefly in a moment. But I just wanted to share that, I really do believe that this topic is both timely and important. As AI continues to transform healthcare, we recognize that pediatrics presents unique challenges and opportunities, some of which were clearly described in Ricky's presentation prior to this. So things like physiologic variation, data scarcity, privacy and regulatory constraints, as well as the need for family-centered and trustworthy solutions. So the goal of today's dialogue is going to be exploring how next-generation AI can really help better meet the needs for our pediatric patients and help make a more meaningful impact for children and families. So I do want to just, again, highlight our panelists here, and thank you all so much for being here. We have a really accomplished group of experts here this morning. And before we begin, I just wanted to say that I'll kind of introduce them and highlight some of their expertise that they bring to the conversation. So first we'll start to my immediate left here. We have Dr. Nima Aghaeepour, who is an associate professor here at Stanford, whose lab develops artificial intelligence and machine learning tools to integrate multi-omics, wearables, and EHR data for translational research focused on maternal and child health. Thank you so much, Nima, for being here. Next, we have Dr. Veena Jones. Dr. Jones is a pediatric hospitalist, vice president, and chief medical informatics officer at Sutter Health, so she joins us from across the way. And she leads system-wide digital innovation and implementation of generative AI tools to enhance clinician and workflows and patient experience. Thank you, Veena, for being here. And then next we have Dr. Sujatha Buddhe. Dr. Buddhe is a clinical professor of pediatric cardiology here at Stanford, who is also a co-director of the non-invasive imaging research and leads the AI task force for pediatric cardiology here as well. And her research focuses on cardiac imaging and integrating AI into clinical practice. And last but not least, we have Dr. Priya Prahalad. Dr. Prahalad is a clinical associate professor of pediatric endocrinology and medical director of clinical informatics here at Stanford. She leads efforts to use AI in remote monitoring for youth with type 1 diabetes, including a recent study that was just published in Nature Medicine and was recognized as a 2025 Top 10 Clinical Research Award. So thank you all again so much for being with us today. All right, so I do want to just start off kind of on a lighter note. Yesterday, I had the opportunity to be here at the 7th annual AIMI Symposium, and really excited, and I'm sure you all are as well, to be part of the inaugural AIMI Pediatric Symposium today. And it sort of got me thinking a little bit about kind of the key differences between pediatrics and adults, and particularly when we think about AI in pediatrics and adults, just kind of thinking about some of those key differences. So I wanted to pass it on to each of you, and I'll start with you, Nima, to describe kind of what you think might be the biggest difference in AI between pediatrics and adults, just based on your experience. If it were up to me, I would love for algorithms in pediatrics to have more stickers and glitter, but that's probably not super realistic. So let's hear from you, and then we'll pass it on to the rest of the panelists.
I think the most exciting thing about AI in pediatrics is the size of the opportunity itself. I know a lot of the people in the VC community like to talk about the market not being big enough. I couldn't disagree more. If you think about the societal impact and the financial impact of what we can do in pediatrics, it's larger than anything in the adult space, because every kiddo that you save in a NICU creates 90 years of life. It's in stark contrast to helping somebody with stage 4 pancreatic cancer at 80 years old live for 2 more years. If you measure impact the right way, both from a societal perspective and from a financial perspective, the opportunities in pediatrics are very large. The other, again, data sparsity is an issue, but it's also an opportunity. On older patients, particularly in end-of-life settings, we have very limited time to collect data. In pediatric settings, we have decades upon decades to collect data. So some of the challenges that often give AI in pediatrics a bad rep are actually really large opportunities that in the long run will be really helpful to us.
Excellent. Thank you so much. And Veena?
Yeah, well, first, thank you so much for the opportunity to be here and to chat specifically about AI in pediatrics. You mentioned the fact that, my role for a large health system at Sutter Health, unfortunately similar to Ricky's shared experience today, I don't get to spend a lot of time thinking specifically about AI in pediatrics. And I'm a pediatrician, right? So this is really fun. And I have to say, I agree with a lot that's been said. I think there are really vast opportunities when you think about the opportunities for AI in pediatrics. I'm the mom of 2 NICU babies, and NICU graduates right here at Stanford. And when I think about the opportunities to leverage such incredible technology to, really take our care of the most vulnerable, arguably, patients that we care for, and to take it to that next level, I think the opportunities are phenomenal. When I think about it from the perspective of a large health system, we really do struggle with the challenges around, the financial, the business case, right, of investing in those types of solutions. But I think places like Stanford and the incredible work that's being done here really are opportune to ignite that change across the world. So I think I really look forward to what the next couple of years will bring in this space.
Awesome. Thank you, Sujatha.
First of all, thanks to Keith, Natalie, and AIMI to put this together. So I think it's amazing to have the first Pediatric Symposium. But in contrast, I think everyone who was there yesterday would see that it was a full-day paid session compared to a half-day free session. So you kind of see the disparity right there between adult and peds. And, as it was discussed all day today, the drugs, even if you look at drugs that we have been using for decades, over 50% of pediatric drugs are off-label use, 80% in neonates, 80% of kids in hospitalized kids get off-label medication. So we are seeing similar trend in AI to projects and products in peds compared to adults. But I think there is more opportunity to narrow that gap in AI than it was in drugs, given all the other tools we have. So I'm more optimistic and agree that there's more opportunity, especially for these tools. So looking forward to that.
And I have to echo everything that everyone here has also said. I think one of the challenges in pediatric AI is data. Now we have children with so many different medical conditions who wouldn't live beyond infancy, who are now living to be adults. So there's decades of data we can collect and improve care as we go forward. But it's also really exciting that we can do this and improve care. And I think the other piece that we haven't fully touched upon is AI can be a tool to help children. So children are often start off with their parents doing their care, and they slowly transition to taking over and then becoming adults. How can we leverage AI to help with that transition, help teach children to be independent with their care, maybe creating bots to help them manage their chronic diseases?
Wonderful. Thank you all so much for those comments. And I do want to just also provide a moment to highlight some of your incredible work. And so I'd love to ask for you to share with the audience some of the work that you're doing to help shape the next generation of pediatric AI, because you really are all at the forefront of innovation in this space. So could you share maybe a highlight of some of the research work that you're doing, and then maybe a key lesson too that you've learned in sort of bringing this into sort of real world pediatric practice? And so we'll start here.
Right. Yeah. So in my journey, I've been gradually going from end of life care to earlier and earlier and earlier. We arrived at the NICU, and there are really great opportunities in the NICUs, but now we are learning that even the NICUs are often too late. And for healthy newborns, you have to start with healthy mothers. So we are doing a lot of work on that interface of labor and delivery units and the NICUs, looking at both of them together. One of the lessons that I've learned as a PhD, not a MD, is that our healthcare systems are extremely fragmented. You have your general practitioner, and then you have your OB, and then the newborn is born, and suddenly a neonatologist walks in who knows nothing about the mother, and then at some point they graduate from the NICU and they have to start working with a pediatrician. I think there is a large opportunity here for AI models that understand the entire mother-child diets, history, and everything that we have known about the mom, particularly for several decades, but also everything that we know about the NICU experience and so on, going well into adulthood. I think all of these can be integrated with a single AI model in ways that are fragmented, the healthcare system currently cannot do.
And Nima, you also recently published in Nature Medicine too about AI-driven approaches to selecting TPN for our NICU patients. Can you just highlight a little bit of that work too before we move on to the panelists? Because I think that that's some really revolutionary work that I'd like to highlight.
Thank you. Yeah. So we had these models that could predict risk of various morbidities in the NICUs far in advance of what neonatologists could do. In some cases, even before birth, they could already predict things like bronchopulmonary dysplasia and necrotizing enterocolitis. And then the question for us became, what exactly are we going to do with this? Are we just going to create yet another dashboard and put it up in the ICU and beep at the physicians who are already alarm fatigued? Turns out that that doesn't work that well. Several RCTs have shown that, partially because people are alarm fatigued, but partially because we don't have effective interventions for many of these conditions anyways. So we started looking in the NICUs for opportunities for interventions to change the prophecy, to change these outcomes that we have predicted. We have multiple projects that are cooking. The one that you're referring to is focused on TPN. We quickly learned that current TPN practices at best are reactionary. We basically say, hey, it looks like your sodium level is too low. Let me give you more sodium. But we have these algorithms that know what's going to happen to the patient 3 months down the road, so we can proactively figure out what needs to go in these TPN bags. And it provides other advantages for mass manufacturing these IV bags and making them available in LMICs with significant price reductions, because the AI can simplify the process and enable mass manufacturing. We have done multiple studies in various institutions showing that the algorithm trained at Stanford works in other institutions just as well. And now, in partnership with various folks in the NICU and Natalie and Keith, we are about to launch a live study in Stanford's NICU.
Awesome. Thank you so much for sharing. Veena, we'll turn it to you to kind of highlight again some work that you'd like to share with the audience to kind of provide some context about some of the next generation AI tools that we're sort of seeing for pediatric patients. I know you said you're not so focused on the pediatric population, but at this health systems level, right, you're really instrumental in helping bring some of these tools into life, into the implementation setting. So I'd love for you to speak about anything you'd like to share.
Sure, absolutely. Thank you. So a lot of my work, like you mentioned, Bethel, is really around operationalizing and implementing technology across a large health system. And so I think Ricky did a great job of describing the different areas of opportunities for AI. And at the bottom of one of his slides, he said, the boring but critical stuff. And I think that's honestly where I do spend a lot of my time right now, because when we think about our ability to implement and scale artificial intelligence platforms, the lowest hanging fruit really is in some of those critical operational efficiency types of work. And so over the last year, one big project that I've led across our health system has been the implementation of our ambient AI listening technology, which is really becoming quite commonplace, I think, at this point. But a year ago, when we first implemented this at Sutter Health, we were one of the early adopters. We started with 100 clinicians, and as of last week, we have over 2,600 active users of the technology, and a large population of those actually are our pediatricians. And I think that there's a lot that we've been able to learn from our pediatric providers in the space. In fact, coming out of that pilot implementation a year ago, when we more broadly opened up the technology, one of the first areas that we saw the largest opportunity for adoption was with our pediatricians. And some of those early champions took this technology to their departments, urged others to sign up, and we have, across our very large geography, huge practices where, for our pediatric clinicians, this has really, really been a game changer. So that's probably one of the biggest areas where I've focused my time. Some of these generative AI technologies to really impact clinician workflow and remove those burdens from our day-to-day. We also, as a health system, look at various opportunities for partnering with companies in the space. And so we have some partnerships in the radiology space around lung cancer detection that we've actually implemented in our system, and improved detection of lung cancer earlier stage to about 70% with the use of AI, whereas previously only about 30% of our lung nodules were being detected in early stage. So several different examples that I'm happy to talk about more, but that's really what I do, is think about how do we take all this incredible research and all these incredible tools that are being developed, and how do we bring them to our clinicians and implement them at a large scale.
Wonderful, and we'll talk a little bit more about some of the challenges you might face kind of in doing so. So we'll pass it over to Sujatha.
Yeah. So by background, I'm a pediatric cardiologist, and often we run into issues as when we do echocardiograms on patients. It's a very good diagnostic tool, but very expensive and not easily accessible. And there are some guidelines on when to do this versus not. So we developed a co-pilot where, not based on fake data, but real patient data over the last 10 years, and said, okay, how many of our patients actually need the echo when it was performed based on guidelines? So we developed an LLM model where we fit in the guidelines and we fit in our notes and trade it well enough. And we realized that about 15% were over-ordered echocardiograms when they were not to be done. And when we look at the reasoning, it's actually very well defined reasons of criteria it picks up as why a patient needed an echo or not an echo, something that I would want my fellow to teach them in the clinics. And I see that the model is actually outputting that as a reason why an echo was not indicated in that scenario. So we are going further with that and saying, okay, but how do we stop this at the pediatrician level? Like probably they didn't even need to come to cardiologists. So fine-tuning the model with EKG data and setting at the pediatrician level saying, this does not even need a cardiology referral, or this one probably needs one. So how do we increase access and reduce cost? And that, but that's like a smaller scale project. But more at the national society level, we are realizing even more that we can't solve these problems in peds as a single center study. So heavily involved in national societies where we are creating registries and cloud-based databases so that research can be done at a more on a multi-center level. However, the barriers we are facing are, unlike other scenarios where we did disease-specific studies, it was relatively easier to share data. But when we want this large-scale data to be shared, we're having several barriers from institutions to share this data. So I think that's where I'm hoping that we'll have more advancement and buy-in from the higher up saying this is needed. Data sharing for multi-center research to happen at national societies, because I think industry sponsorship is great, but I think medical institutions have to start the work first.
Awesome, thank you. And yes, that was a very compelling study looking at kind of appropriateness for echocardiograms. So thank you for highlighting that. Priya?
So the work that I'm working on is bringing remote patient monitoring to children with type 1 diabetes. So there was a landmark study from over 30 years ago that showed that frequent insulin dose adjustments can improve clinical outcomes in children who have type 1 diabetes. So this is diabetes where they're unable to make insulin and require insulin. But the idea of doing these frequent dose changes just has not been able to be implemented for various reasons. Technology happens to be one of them, but clinician work time is the other. And so in our study, with the advent of continuous glucose monitors, which are wearables that measure glucoses every 5 to 15 minutes, we've been able to use that data to build a remote monitoring program. So this data can be shared remotely to a provider. And we've built an algorithm that analyzes this data and highlights the people who would most benefit from intervention. So that was the AI piece of it. But a large part of this was also developing a dashboard or design to make this usable for providers. So we partnered with the engineers and some designers to build a dashboard that can be used for population health management to identify who needs to be contacted. And we've been able to do remote patient monitoring and dose changes once every week to month, when previously it was once every 3 months. And we've seen improvements in hemoglobin A1C of 1.1% over 1 year. And our division chief likes to joke that if you had a diabetes drug that dropped your A1C by 0.3%, it would be worth billions of dollars. So this has actually had really big impacts. And so our next step with this is to try to spread this to other centers to show that having this AI-enabled dashboard can help other centers improve their clinical outcomes. But I think one of the challenges we've encountered as we've gone through this is just data access. There's always this question of who owns the data. Is it the manufacturer? Is it the health system? Is it the patient? And I think many people would argue it should be the patient. But the data is often locked behind proprietary software. And so we've only been able to partner with one right now to bring this data in. And we're trying to encourage other people to open up the data. So currently we can only do this with continuous glucose monitoring. But now there are also insulin pumps or automated insulin delivery systems. And we haven't been able to get them to open up the data for us to do this dashboard. And so we're running into workflow issues where we're able to see the CGM data, analyze it, and then our care team has to go to a different platform to analyze pump data manually. And so this can actually be a limit to scalability. So I think one of the real big things we want to see is data opening up so that we can integrate more algorithms to help improve remote patient monitoring and bringing care to the patient at home.
Wonderful. Thank you all so much for sharing wonderful examples of developing AI that is clinically relevant and specific to the needs of our pediatric patients. You guys highlighted a few sort of challenges in sort of bringing these, the research and sort of implementation into the real world practice of pediatric care. And then just wanted to shift gears and ask if you could just sort of address maybe some effective strategies that you think would be helpful for addressing those challenges to make sure that we are realizing these important solutions for our pediatric patients. Priya, we'll start with you and go backwards.
Okay. So one of the challenges that I brought up was the accessibility of data. And so I think partnering with industry to talk to them about how we're using this data, how we can use this to improve care is one of the ways, and I think which we can improve the algorithms. And there need to be good agreements that we're not going to reverse engineer their systems. We're not going to try to build a better, let's say, closed loop system off of their data. But this is really for clinical care, having partnerships with industry, having partnerships with engineering teams. Our IS team, we've worked really well with our IS team. And then I think the other thing is, again, data is in different places, but eventually getting to a place where we can bring it all into, for example, the medical record, so we can use factors from clinic visits and not just numbers and patient factors to help drive improved care.
Sujatha, go ahead.
Yeah, completely agree with everything said. I also think we're resorting to more federated learning projects so that to tackle these issues of data sharing. Another thing is when we started the AI task force in cardiology, we were going in different directions. But then when we met with Keith and we saw what's the roadmap for the pediatrics division, versus where we were trying to go, it was so different. So I think actually having an idea of where your institution is lined up and having your goals aligned with that also helps make more real progress. And another thing is also, I hope, like, there's a lot of redundant efforts, like what I'm doing in cardiology may be done in endocrinology or in another institution. So more transparency in this. So often we see that in medical research, right, there's a long lag between when you do something versus when it's published and it's more aware to everyone. And that won't work in AI, where the technology is advancing much more faster than that. So we should have more transparency in how things are progressing, learn from each other's mistakes and success, and kind of build on that rather than starting from first.
And Veena, specifically for you, I'd love for you to talk a little bit more about kind of the implementation phase. And you sort of alluded to this, but this is really the stage where a lot of innovations can sort of either succeed or stall. Could you specifically talk about some of the practical, sort of ethical, regulatory challenges that come with that sort of implementation stage of these innovations?
Sure. I think I just want to highlight something that I think about a lot when we talk about implementing any kind of technology, but we're talking about AI today. And again, I think the stage was set for us earlier today when we talked a little bit about various groups and their appetite for AI or for technology, right? So we've got our adolescents and our younger generation that use AI almost every day, and many clinicians who use it as well in their everyday life, but are hesitant to use it in their clinical work, right? And so a lot of what we need to implement technology is buy-in, right? We need the clinicians that actually who we want to use this technology to recognize the benefits and be willing to use it. So, one thing that we've done at our health system, and actually just had a big session on last week, was our CEO brought together our top 500 leaders across the organization and had a couple of hour session really just talking about AI. What is the future of AI? What does it mean for healthcare? What does it mean for our clinicians? And the time is now, right? If we're not adopting it, if we don't have that appetite for it, we will be left behind. This isn't something that's going to go away. And so, the change management piece of implementation is so incredibly important, but it's also one of the hardest things. And I think really having open dialogue, such as what we're having here, is something that's been really critical as I've worked to implement these types of technology. Governance around our approach to artificial intelligence has been a really important thing, and also a culture shift in terms of thinking about AI not just as a tool or a platform, but as something that we are working to grow and to cultivate as our partner when we think about care delivery. So those are some of the, I think, key challenges that I face. But again, I think there's a lot of opportunity for all of us here as we think about advocating.
I want to actually shift focuses a little bit to scalability. And to you, Nima, I'd like to ask if you can share some of the unique challenges and opportunities when introducing next generation AI tools, like some of the ones you've described, at scale in these clinical sort of workflows in the pediatric setting.
Yeah, so scaling has been, to my surprise, a lot of fun. When initially I was super scared that, we are training a model at Stanford, is it going to work on the East Coast? Turns out that human physiology is not that different from the West Coast to the East Coast. Clinical practices are often different, but those practice differences are usually not scientific and backed by RCTs. They are more cultural. So the differences that you see in those practices often can be challenged pretty easily. Scaling in terms of implementation has been really fun. Our TPN paper, for example, came out, and a whole bunch of hospitals, without us reaching to them, really, really wanted to use it, which is fantastic. This wouldn't happen that easily on the adult side, just because of how crowded the AI space over there is. But in pediatrics, that's been actually a lot of fun. One of the biggest tips that I would share is that I make it almost mandatory for everybody in our lab to spend at least 3-4 months in the Graduate School of Business, not because I want everybody to start a company around their projects, but because I want them to understand that there is more to building real solutions than to just take a data set and predict an outcome and call it a day and publish a paper. You have to understand the full landscape out there. You have the hospital's leadership who are trying to run a very complex business with very narrow margins. You have the providers who are trying to do their best for the patients. You have the patients who are worried and scared about their children and have questions about ethics and AI and data privacy. And you can't just build something that makes one group happy and call it a day. If you want to go beyond just publishing papers and building solutions that actually get implemented and actually help patients, you have to understand everything from the patient side to the payer side and build something that addresses everybody's needs. It's a complex problem. Often these needs between these stakeholders sometimes conflict with each other. And I really encourage people in our lab to start thinking about that early, to map that out. And if they have a solution, if they have an answer for how a project is going to get scaled, then you can go ahead and spend a couple of years building the models and curating the data sets and so on. This is really baked into Stanford's culture with design thinking and biodesign and so on. We try across the board at all levels, from trainees to faculty, to teach this to everybody. It's not practiced as much in AI as it should be because it's so easy to grab a data set and start building models. But we really, really have to start with mapping out the entire pathway of how is this thing going to get implemented? How is it going to make everybody happy in the entire map of stakeholders before we start just building models?
Thank you so much, Nima. And we'd be remiss if we didn't talk about engaging families in this process. Obviously none of this happens in a vacuum, and our families, patients and families are very much impacted by the use of AI. And so I wanted to pass it over to Sujatha to just comment about kind of how we can more meaningfully engage our families in these discussions as we develop AI tools, and then also just being mindful of the time. So this may be our last question before we open it up to the audience.
Yeah, I would say that's where the ethics come in, is how do you consent for studies? It's not just the patient, the family is a minor or under 80-year-old who can give an assent versus a consent. So all of those are really important, and clarity about data sharing has to come from all the family. And I'll also say as the future, and just to add on the scalability, I think it's not just thinking of how do we scale the project at hand, but also thinking of opportunities that have an impact on a global scale. For example, we are thinking of an example where hypertrophic cardiomyopathy, it's a heart condition where you can have very devastating outcomes and underdiagnosed. And the current pathway for that is you go to your pediatrician, you fill a questionnaire, poor sensitivity, you get an EKG, poor sensitivity, and then you go to a cardiologist, which is a long test and with a high cost to get the diagnosis, which is not accessible to everyone. So we are working on something where a single image could get you the diagnosis. So imagine how, if you have this on a handheld tool, this can be done at a pediatrician's office. This can be done scalable across the world, anywhere. So I think that's another view of scalability and impact that you can think in peds as you're thinking of projects. And how do you influence the whole family with your product?
Wonderful, thank you. And that was going to be kind of my last question, was about sort of equitable access and adoption. And so I'm really grateful that you sort of highlighted that point as we sort of move on to questions from the audience. So I just want to say thank you again so much for all of your work, but also for being here and being a part of this important conversation about the future of AI in pediatric medicine. And so I do want to just open it up for questions from the audience. We have about 10 minutes, and there's microphones going around the room here. So I see a few hands.
I'm now in the research side at Stanford for AI development and evaluation, but my whole career to date has been in medical device development. And so when you guys made the comment about how, drugs for pediatrics has been around a lot longer than AI for pediatrics, but 80% is off-label use. Is that just accepted now? Like there's no efforts to, to make drugs specifically for pediatrics, and so curious about. Are there things we can learn from that industry, and actually, do we have to should we join forces in that front so that both AI and drugs can be used for pediatrics officially versus off-label?
I wish we have approval for everything, but I can quote an example where there's a drug used for remodeling of the heart, which is very well studied in adults. And with heavy funding, it was done in peds over years. We just could not get the enrollment. So after 5 years, they stopped the study, and we still use it every day. So I think it's the barrier is still going to be to get the numbers to reach significance. And sometimes when people believe that it's too late, these studies take too long, and people believe that this drug adds value, then they're not going to randomize a child into no drug just to prove that it's efficient in an RCT. So I think those are all those ethical considerations that play heavily when there is so much lag in getting that product out to our patient, that we have to use it when that's the last resort for our patient. So I think with AI, I'm hoping, given that how rapidly you can turn out these products, you probably have more opportunity in narrowing that gap hence rather than the drugs.
Thank you.
Hi, I'm Abby. I'm a pediatric hospitalist, and I have a question just specifically, Sujatha, a little bit about what you talked about the use case of AI tools being able to direct clinicians to more evidence-based medicine and being able to determine situations in which there's overuse of care. My question is, though, about kind of piggybacks off of the last question. So when we have the scenario in pediatrics where we're essentially off-label using a lot of the technology, how do you think about how health systems should leave room for sort of clinical judgment if you've got a situation where the tool is directing you in a particular way, but wasn't trained necessarily on a heavily pediatric data set? What does that look like, and what do you imagine that? That's my first question. And then my second question, touch a little bit on what Ricky had talked about earlier. So the idea that clinicians are going to be probably moving towards more complex cases back to back, and that AI tools will be able to offload easier cases. And the idea of sort of clinician burnout and people thinking about clinicians about what makes your day kind of exciting is you have a hard case and then you let off with an easy case, and then you have a hard case and you let off with another easy case. And so what does a clinical day look like if you're primarily managing complex cases back to back?
I think coming to your first question, as when the tool is directing you in one direction versus your judgment is saying something else, I think it's always nice to have another tool assisting you, so hence it won't replace you, it'll just assist you. And sometimes it's just missed documentation. So it'll also assist you in things you're missing to document or not thinking of, which and direct you in the right direction. So I think it's always going to be a great assistive tool to help you. And the second thing of, I think, complex to complex patients, I think we all enjoy seeing and providing that complex care. What we hate is doing the work around it, right? The notes, the follow-ups, which are really could be done, delegated to someone else. So as long as that's taken care of, and that's why we are in these institutions where we just get referred to complex patients. So I think we will have enough variability that will still enjoy practice as long as the redundant stuff and the unnecessary stuff is taken care of by AI.
I mean, if I could just add, I think you're highlighting, Abby, the direction I would argue we've gone in medicine even to date, right? I think the type, as a pediatric hospitalist as well, I mean, the types of patients that we used to take care of in the hospital setting has changed significantly over time, right? When you look at the care that can now be delivered at home, and absolutely, I think AI is really going to continue to shift that scale. But it's why the open acknowledgement and discussion around how clinical practice itself is evolving with artificial intelligence is really important. So I think we've yet to see some of the impact, and we'll learn a lot even in the year to come.
And just to add on, sorry, my job as a cardiologist is much easier because I'm just looking at the heart and I have all the tools. The pediatrician is the one who in 15 minutes has to decide which one of the 20 specialties he needs to refer the patient to. So I think all the tools that can assist the pediatrician in that decision-making will be very impactful.
Yeah, hi. I'm a pediatrician based in New Jersey. I have my own private practice. Very much using Scribe, through the EMR that is not integrated, but we're still using it. I'm very interested in exploring the opportunity of neuromodulation for autism. That's why I'm here to get connected. So very much into AI. Have been doing this for the last 2-3 years, but something just comes up to my mind that isn't being discussed. So if you're using a Scribe, some of the things, like if I'm reading everything AI is doing for me, then what is the use of AI? So if there is something happens and there is a malpractice lawsuit, does the malpractice says that they won't cover us because it's AI? Or do I need another malpractice for AI? Or has ever been this discussed? Like, yes, we are not hesitant to, we have to use it. You have to embrace it or you're out, right? So there are not much choices about it, but has that ever been discussed? Because I think if I talk to my malpractice insurance, they might say that you were using AI, so we're not going to cover. So has that been ever added, discussed, and
Yeah, there's certainly discussions about the legal implications, but I'll hand it over to either Veena or Nima. It looked like you were going to say something.
So I don't know about malpractice issues and so on, but I will answer an adjacent problem of, are we losing something by over-relying on these ambient AIs and scribes and so on? Earlier in my career, I thought that any disease that I'm trying to predict, I'm probably going to get most of my signal out of lab values and other objective information in a patient's medical record. And it's been humbling for me to see how much of our predictive power often comes from unstructured notes that physicians wrote. And now in hindsight, that's not surprising. It's a summary of all of their judgment, everything that they think is going on with this patient that is not necessarily captured in structured data. And I think by over-relying on AI systems for writing these clinical notes, we may be risking losing some of that intuition that is captured in a human written note. Can that down the road have other effects and become a litigation issue and so on? Possibly, but more than the litigation issues, I'm worried about loss of that human intuition when an AI model is in charge of writing all the notes.
Thank you.
Thank you for that question.
Hi, thank you so much for an amazing panel today. I had one question that has been on my mind a lot recently. The unique aspect of pediatrics now is that the significant degree of Medicaid cuts that we are seeing. And so in this aspect, our health systems are a lot more stressed to deliver pediatric care and rapidly transforming that. What are ways in which we can continue to advocate for AI innovation in this stressful time? And what are the use cases that you feel would be most beneficial for our patients, the highest impact from your individual perspectives?
I'll start. So we have a fair number of patients with Medicaid, and for a lot of what we're using AI for, we rely on wearable technologies. So far, these technologies have been covered. It took several years of us advocating with our state Medicaid to get it covered. And now we're seeing this technology, continuous glucose monitor specifically, being taken away from some of our patients with type 2 diabetes, which is an increasing population in the pediatric population. And I think with respect to that, it really comes down to advocacy, not just from the physicians or the care providers, but also advocacy from the families about how much of a difference it makes and how do we reprioritize funds to help support this. And I think with some of these AI innovations, the other thing we really need to think about is how do we use these innovations in a way that we don't leave people behind. And so in the diabetes space, closed loop systems, their algorithms are a form of AI, and they're really great at helping people have improved glucose outcomes. But with cuts, are there going to be specific requirements to get these systems? And what we really need to show is that this technology benefits everyone, not just those who are meeting certain criteria. And in fact, in the diabetes space, we've shown that these closed loop systems help those who have the worst outcomes do much better than the ones who are already doing well get a little bit better. And so I think the real big thing is we have to just keep advocating and talk about the importance of not leaving children behind with all of these Medicaid cuts.
We have time for one more comment from the panel.
Yeah, I would say, I mean, that's absolutely true. And also I would use the National Society, especially AAP, like they have a voice and they advocate for many things. So I think reaching out to them, I'm heavily involved in AAP. And we do a lot of advocacy, but I would say we are very slow in the AI world and trying to catch up there. But I think they have a huge role to play.
All right, well, I wish we had more time for questions, but unfortunately that concludes our session this morning. So please join me in giving a round of applause to our panelists for a thoughtful discussion. Thank you all so much for being here again.